You know that feeling, right? That overwhelming sensation of being utterly swamped by information. You've got countless tabs open, maybe research notes scattered everywhere, articles piling up.
Mm.
It's that familiar, almost dizzying sense of drowning in data, trying desperately to piece together a coherent picture, to grasp what's truly important.
Yeah, information overload is definitely real.
Totally. Well, imagine having a trusted guide to navigate that information ocean with you, pointing out the hidden gems, the surprising connections, and distilling everything into crystal clear insights. Forget the overwhelm. Welcome to the deep dive, your ultimate shortcut, your expert guides, here to distill that complex information into surprising revelations and truly actionable knowledge, all custom tailored just for you.
Okay, let's unlock this. Today, we're plunging into a truly fascinating collection of sources that offers an intimate peek behind the curtain of how our bodies function, how we support them through modern medicine, and some of the profound challenges they can face.
Yeah, it's like a rapid fire masterclass in vital medical concepts all kind of pulled together for us. Exactly. We've received this incredible stack of notes that touches upon crucial aspects of human physiology and pathology, from the essential fluids that literally sustain life to the intricate, perfectly timed mechanisms of medication, and even the silent threats of cellular overgrowth that lead to complex diseases.
Right.
Our mission today is to unpack these fundamental concepts, to truly understand their immense significance, and to reveal the often overlooked, surprising details that connect them all.
What's truly fascinating here, I think, is how these seemingly disparate pieces of information, the types of fluids we use, the specifics of insulin, the definitions of certain cancers, they're all profoundly interconnected.
Mm-hmm.
If we connect this to the bigger picture, it doesn't just highlight the precision and complexity required in understanding human health, it reveals the incredible dynamic choreography that's constantly at play within us. It's not about memorizing isolated facts, it's about seeing the delicate balance, the intricate machinery, and sometimes, the unexpected vulnerabilities that shape our well-being every single day.
Let's begin with something you've almost certainly encountered, whether directly or indirectly: intravenous or IV fluids. When you see that bag hanging by a hospital bed, often clear and seemingly simple, it's easy to assume it's just, water.
Right, or maybe just salt water.
Exactly. But it's far more than that, isn't it? There's an entire universe of science behind what goes into that bag and, critically, why it's chosen for a particular situation.
You've hit on a crucial point there. While often generically referred to as saline, the world of IV fluids is incredibly nuanced. It's really a testament to the body's delicate internal environment.
Ah.
These aren't just simple hydration tools. They are essential medical instruments, used for everything from restoring basic fluid volume and correcting electrolyte imbalances to acting as precise delivery systems for life-saving medications directly into the bloodstream. The absolute core distinction between these diverse types of IV fluids lies in a fundamental concept called tonicity.
Tonicity. Okay, that sounds a bit technical. Can you break it down for us? Maybe give us a way to really grasp what it means in practical terms.
Sure. Think of tonicity as basically the concentration of dissolved particles.
Yeah.
Things like salts, sugars, proteins in a solution. Specifically, how that concentration compares to the concentration inside your body's cells or within your blood plasma.
Okay.
This concentration is profoundly important because it dictates how water will move across those tiny cell membranes. Water, always wants to move from an area of lower solute concentration to an area of higher solute concentration. It's trying to equalize things.
Oh, like osmosis?
Exactly like osmosis.
Yeah.
This movement, or lack thereof, is a huge deal for cell function and overall fluid balance. So we categorize IV fluids into three main types based on this tonicity: isotonic, hypotonic, and hypertonic.
Right. Isotonic, hypotonic, hypertonic. So if water is always chasing this balance, what does each of those types actually do to our cells? And why would a doctor choose one over the other?
Okay, good question. Let's start with isotonic solutions. These have a solute concentration that's pretty much identical to your blood plasma.
So balance.
Balanced, exactly. Because the concentrations are balanced, there's no significant net fluid shift into or out of your cells. Think of it like adding water to a glass that's already filled to the same level with a similar liquid. Nothing really changes dramatically in terms of the cell size. These are your baseline, your steady-state solutions. Then you have hypotonic solutions. These have a lower solute concentration than your blood plasma.
Lower. Okay.
So when these enter the body, the water within the solution wants to move into the cells, which have a relatively higher concentration inside. This causes the cells to swell up a bit.
Like they're soaking up the extra water.
Precisely. Imagine your cells are like thirsty sponges, and you're giving them water that's purer than their own internal fluid, so they soak it right up. And finally, we have hypertonic solutions. These have a higher solute concentration than your plasma.
Higher, so the opposite effect.
Exactly the opposite. In this case, the water inside your cells is drawn out into the surrounding, more concentrated fluid. This causes the cells to shrink. Picture those cells like, I don't know, overhydrated grapes, and the hypertonic solution pulls their internal moisture right out.
Okay, shrinking cells. That sounds potentially problematic.
It can be, absolutely. Which brings us back to your question. Why do we have so many options? Why not just stick with one?
Yeah.
It's precisely because the body's fluid compartments are incredibly dynamic, constantly shifting, and often they require exceptionally precise manipulation to correct imbalances that, if left unattended, can quickly become life-threatening. The complexity of the fluids reflects the body's own intricate design.
That makes perfect sense. So these isotonic solutions, the balanced ones, they're generally the go-to, the physiological baseline. But our notes mention several different types of isotonic solutions. So even within this balanced category, there are choices. What are they, and why pick one over another? It's not just grabbing the nearest bag.
Absolutely not. You're right. While they all aim for that balanced state, their specific compositions offer different, sometimes subtle advantages that could be crucial depending on the patient's condition. An isotonic solution, by definition, has that similar solute concentration to blood plasma, ensuring no major fluid shifts.
Right.
Their primary use is for volume expansion, basically, increasing the amount of fluid circulating in your blood vessels. This is vital in situations like significant dehydration, blood loss, or various forms of shock. They're also excellent carriers or diluents for administering many medications safely.
Okay. So what's the most common one? The one we probably see most often?
That would definitely be 0.9% sodium chloride. Everyone knows it as NS or normal saline.
Normal saline.
It's essentially just salt and water. It's everywhere in healthcare because it's highly effective at expanding that intravascular volume without causing fluid to rush into or out of cells too drastically. It maintains hydration without messing with the cells too much. It's the workhorse, really, the general purpose solution.
Okay, the basic salt water. But then I've definitely heard of lactated ringers, or LR. What's the deal with that one? Is it just fancier saline?
Fancier saline isn't too far off, actually. Lactated ringers, or LR, is also isotonic, but it has a more complex electrolyte profile. It's designed to mimic the body's natural extracellular fluid even more closely.
How so?
Well, it includes not just sodium and chloride like normal saline, but also potassium, calcium, and crucially, lactate.
Lactate, like lactic acid.
Sort of. The lactate in LR isn't just a random addition. It gets metabolized by the liver into bicarbonate.
Bicarbonate, like baking soda. Well, not exactly, but the body's buffer system.
Exactly. Bicarbonate is a key buffer in the body, helping to counteract acidity. So LR can be immensely beneficial for patients experiencing certain types of metabolic acidosis. Think situations like severe burns, major trauma, big surgeries where fluid resuscitation is critical, and maintaining metabolic balance is a big concern.
So it's a bit more tailored than plain saline for specific, more complex situations.
Precisely. And then there's 5% dextrose in water, or D5W. Now this one is interesting. It's a bit of a chameleon.
How so?
When it's in the bag, the dextrose that's a sugar makes it isotonic. So concentration-wise, it matches the blood initially.
Okay.
However, once it's infused into your body, your cells very rapidly metabolize that dextrose for energy. They just gobble it up.
Right. Sugar is energy.
And once the sugar is gone, what's left?
Just water.
Essentially, yes.
Yeah.
Free water. This causes it to physiologically behave like a hypotonic solution inside the body, even though it started isotonic. We'll get more into hypotonic in a second, but it's a key insight.
Wow. Okay. So it changes its properties after you give it. That's clever.
It is. And finally, our notes mention Ringer's solution. It's similar to lactated Ringers, but doesn't have the lactate. It's used much less commonly than LR these days. So all these isotonic options, despite their subtle differences, are really about maintaining that delicate fluid balance without drastically altering cell size or fluid compartments. They're the body's gentle, steady balance keepers.
That whole D5W thing is fascinating, a solution that shifts its behavior. Okay, so if isotonic is about keeping things balanced, hypotonic sounds like it's specifically designed to push water into places, to hydrate the cells themselves. You said it causes cells to swell slightly? Why would we want to do that? Isn't swelling usually bad?
That's an excellent question, and it really highlights the precise almost targeted application of these different fluids. You're exactly right. Hypotonic solutions have a lower solute concentration than blood plasma, and their main goal is to hydrate cells by causing fluid to shift into them from the bloodstream.
Okay.
And yes, we absolutely want to do this when the cells themselves are dehydrated, rather than just needing more volume in the blood vessels overall.
Can you give an example? When would cells get dehydrated like that?
Sure. Think about conditions where the blood has become too concentrated. Maybe someone is severely dehydrated or they have way too much sodium in their blood, a condition called hypernatremia.
Hypernatremia. Okay. High sodium.
Right. In those cases, water has actually been pulled out of the cells, leaving them shrunken and struggling. Or consider certain phases of treating diabetic ketoacidosis, or DKA. Once the dangerously high blood sugar is brought down, the body's cells often remain profoundly dehydrated, really parched.
Ah, I see. So you need to get water specifically back into those cells.
Exactly. In these critical situations, hypotonic solutions are indispensable for directly rehydrating those cellular compartments and restoring their normal function. Our sources list several specific examples of these more diluted solutions. 0.45% sodium chloride, often called 1-NS, meaning half-normal saline.
Half-strength saline, basically.
Yep. Then there's 0.33% sodium chloride, or OANS, and 0.225% sodium chloride, or 1/4-NS. These are all progressively more dilute saline solutions designed specifically to provide that free water that can then move into the cells.
And going back to D5W, that chameleon solution, how does it fit in here again? It starts isotonic, but acts hypotonic.
It's such a neat concept, isn't it? It really highlights how the body's own metabolism interacts with these fluids. As we said, D5W is isotonic in the bag due to the dextrose, but your body is super efficient at metabolizing that sugar.
Gobbles it up.
Right. Once the sugar's gone, you're left with essentially pure water in the bloodstream. And that free water then moves into the cells via osmosis to rehydrate them. So you administer it from an isotonic bag, but its ultimate desired effect after metabolism is cellular hydration. It acts functionally hypotonic.
That's a really important distinction. But you mentioned risks earlier, cerebral edema.
Absolutely.
Mm-hmm.
Using hypotonic solutions requires significant caution and really careful monitoring. Because they cause fluid to shift into cells, there's always a risk of cellular swelling or edema.
Right.
In most tissues, a little swelling might not be a huge deal, but in the brain, which is enclosed in the rented skull, any significant swelling cerebral edema can be incredibly dangerous. It increases pressure inside the skull, potentially causing severe neurological damage or even death.
Wow.
So while these solutions are absolutely essential for treating conditions like hypernatremia or cellular dehydration and DKA, they're always used very carefully, often diffused slowly, with constant checks on the patient's neurological status, electrolyte levels, and overall fluid balance. It's a perfect example of medicine being this delicate balance between powerful effects and potential risks.
Okay, we've covered isotonic for balance, hypotonic for hydrating inside cells. Now we get to hypertonic solutions. The name implies more concentrated, and you said they draw fluid out of cells, causing them to shrink. This sounds like a pretty aggressive approach. When would you need such a powerful intervention? It sounds almost like a last resort.
You're right. It is a powerful and often critical intervention. Hypertonic solutions have a significantly higher solute concentration than blood plasma. Their main immediate function is to cause fluid to shift out of cells and into the bloodstream.
Pulling water out.
Exactly.
Yeah.
This does expand the volume in the blood vessels, but more importantly, it can reduce cellular swelling. And yes, these are typically reserved for very specific, often acute and quite serious, even life-threatening clinical situations. Our sources list several examples, and you'll notice they are much more concentrated than the others. We're talking about 3% sodium chloride, 3% NS, and even 5% sodium chloride, 5% NS.
Whoa, 3% and 5% salt. That's way saltier than normal saline.
Way saltier, far saltier than seawater even. Then there are combinations that add dextrose to saline, like D5NS, 5% dextrose, and 0.9% ACL. The saline part is isotonic, but adding the dextrose makes the whole solution hypertonic, increasing its power to pull water into the vascular space.
Okay.
Similarly, D5NS, 5% dextrose and 0.45% ACL, combines dextrose with a hypotonic saline base, making it hypertonic overall. And D5LR, 5% dextrose and lactated ringers, does the same with LR. The dextrose always bumps up the overall concentration.
So these super concentrated solutions are designed specifically to pull water out of swollen cells. When is that absolutely necessary? What are the main uses?
Precisely. Their uses are very specific, often representing emergency interventions. For example, in severe cases of hyponatremia, that's dangerously low blood sodium levels.
The opposite of hypernatremia.
Right. In severe hyponatremia, cells throughout the body, especially brain cells, can swell up dangerously, leading to that cerebral edema we talked about.
Ah, okay. So you use hypertonic saline to pull water out of those swollen brain cells.
Exactly. Solutions like 3% NS or 5% NS are used to rapidly, aggressively draw fluid out of those swollen brain cells, aiming to prevent or reverse life-threatening neurological damage. They might also be used to reduce dangerously high intracranial pressure after certain head injuries, again by reducing brain swelling. Our sources also make a really crucial point about TPN, or total parenteral nutrition, and they specifically note central line only.
Central line only. Why is that so important? What is TPN exactly?
TPN is a highly concentrated, nutritionally complete solution. It provides everything, carbs, proteins, fats, vitamins, minerals, directly into the bloodstream for patients who absolutely cannot eat or absorb nutrients through their digestive system.
So IV feeding, essentially.
A very complex and concentrated form of it, yes.
Yeah.
Because TPN is so intensely concentrated, it's profoundly hypertonic. If you tried to infuse it through a regular peripheral IV, like in your arm or hand,
Bad news.
very bad news. It would cause immediate severe irritation, inflammation, phlebitis, and potentially destroy that smaller, delicate vein.
Ouch. Okay.
Therefore, it must be delivered through a central line that's a catheter placed into a large, high-flow vein, usually in the neck, chest, or sometimes the groin. The huge volume and speed of blood flow in those big central veins immediately dilutes the concentrated TPN, preventing damage to the vessel wall.
That central line only detail really drives home the power and the potential danger of these hypertonic solutions if they're not used exactly right. It really does sound like a tightrope walk.
It absolutely is. This class of fluids especially truly showcases how incredibly specific and powerful modern medical interventions can be. That central line only rule for TPN isn't just a logistical detail. It reflects the sheer intensity of these solutions and the body's delicate, sometimes fragile response. Administering any hypertonic solution demands extraordinary care, constant monitoring of fluid balance, electrolytes, vital signs, neurological status, precisely because of the high risk of rapid fluid shifts, fluid overload, or dangerous electrolyte swings. It's a powerful tool, an essential one in critical care, but one that must be wielded with absolute precision and vigilance. Even slight miscalculations can have severe consequences.
Okay, from the precision needed to balance fluids, let's pivot to another incredibly precise internal regulation system, managing a blood sugar. Many of us know about insulin, maybe through family or friends managing diabetes. But if our bodies just need insulin to handle sugar, why isn't there just one kind? Why this whole spectrum of insulins? It feels maybe unnecessarily complex.
It might seem that way at first glance, but it's actually a reflection of how incredibly dynamic our body's needs are. You're right, insulin is that crucial hormone made by beta cells in the pancreas. And its main job is regulating blood glucose. It's like the key that unlocks our cells, letting glucose in from the bloodstream for energy or storage.
Right. Without it, sugar builds up in the blood diabetes.
Exactly. Now, the reason for all the different types of insulin is that our glucose needs aren't static. They change constantly throughout the day and night.
How so?
Well, even when you're fasting, sleeping, just sitting around, your brain and other vital organs need a steady, continuous trickle of glucose to function. That's your basal or background need.
Okay, a baseline requirement.
Right. But then, when you eat a meal, especially one with carbohydrates, you get a rapid and significant surge in blood glucose. That requires a quick, proportionate burst of insulin to handle it efficiently and bring levels back down.
Ah, so you need slow and steady and fast bursts.
Precisely. A single, one-speed type of insulin just couldn't effectively handle both that continuous background need and those sudden mealtime spikes. So the different types of insulin, with their varied onset times, peak times, and durations of action, are all about trying to mimic the body's natural, finely tuned insulin release pattern as closely as possible. It's about matching the rhythm of daily life. So to cover that continuous background glucose need, basically, to keep the lights on, metabolically, we use what are called basal insulins, or long-acting insulins.
Long-acting. Makes sense for the background coverage.
Exactly. These are specifically designed to provide a steady, consistent level of insulin over many hours, often with little or no peak. They mimic the body's continuous basal insulin production throughout the day and night. The goal is stable blood sugar between meals and overnight, preventing those background rises and smoothing out the peaks and troughs.
Okay, so these are the foundation. They keep things level even when you're not eating. What are some specific examples our sources mention? Are there important details about using them?
Our sources highlight a few key ones. One of the most common is Lantus. The generic name is insulin glargine. Lantus is known for being relatively peakless. It gives a remarkably flat, sustained insulin release over a full 24 hours for many people.
Consistent control.
Right. Now, a critical detail about Lantus, mentioned specifically in our notes, is that it has to be refrigerated. Well, before opening usually, storage varies, and crucially, it can't be mixed with others.
Can't be mixed. Why not?
Because Lantus works based on its specific formulation, which forms microprecipitates under the skin, allowing for slow release. Mixing it in the same syringe with other insulins, which usually have a different pH, can actually alter its structure and change how it's absorbed, making its action unpredictable. So that's not just a handling tip. It's vital for ensuring it works as intended and for patient safety.
Okay, good to know. What else is in this category?
Another one mentioned is Basaglar. This is what's called a biosimilar to Lantus. It's highly similar in structure and activity, offering a comparable long-acting option.
Biosimilar, like a generic, but for biologics?
Essentially, yes. More complex than traditional generics, but the idea is similar, a highly comparable alternative. Then there's Toujeo. This is also insulin glargine, like Lantus, but it's a U300 formulation.
U300, what does that mean?
It means it's more concentrated. Standard insulin is U100, meaning 100 units per milliliter. A Toujeo is U300, so 300 units per milliliter.
Ah, 3 times as concentrated.
Right. This means patients needing larger doses can inject a smaller volume of liquid, which can be a big plus, just more comfortable. It also contributes to its ultra-long-acting profile. It lasts even longer, sometimes well beyond 24 hours, providing very stable, extended background coverage. These long-acting insulins are all about that foundational control, setting the stage for managing the mealtime spikes.
Okay, so if the long-acting insulins are the steady background hum, keeping the baseline in check, what about those big glucose spikes after meals? That's where these mealtime managers come in, right? Sounds like they need to act fast.
Precisely. Regular and rapid-acting insulins are the mealtime specialists. They're designed specifically to cover the carbohydrate intake from meals and prevent those post-meal blood sugar surges. You typically take them just before, or sometimes right after, eating to match the incoming glucose.
Okay. And there are different speeds, even within this group.
Yes, 2 main categories here, primarily based on how quickly they start working. First, we have the regular insulins. Our sources list Humulin R and Novolin R.
R for regular.
R for regular, exactly. These are often called short-acting insulins.
Yeah.
They generally start working within about 30 minutes after injection.
30 minutes. Okay.
They usually peak, meaning have their strongest effect around 2 to 3 hours later, and the whole effect can last up to maybe 6 hours. Because they take about 30 minutes to kick in, people usually need to inject them about half an hour before they plan to eat to time it right with digestion.
Got it. Half-hour lead time. But then there's rapid acting, which sounds even faster. More convenient, maybe?
Exactly. The rapid-acting insulins were a major leap forward because they work much faster, offering significantly more flexibility. Our sources list several key examples. Insulin Lispro, brand name Humalog, insulin Aspart, brand name Novolog, and insulin Glulicine, brand name Apidra.
Humalog, Novolog. Those sound familiar. How fast are they?
These typically start working within just 5 to 15 minutes.
Wow, much quicker.
Yeah, and they reach their peak effect in about an hour and are usually gone within 2 to 4 hours. This rapid action means you can often take them literally right before you eat, or sometimes even just as you start eating, without risking a big sugar spike afterwards.
That seems like a huge lifestyle improvement, much less planning needed.
It really is. It makes managing meals much easier, especially if meal times or amounts are unpredictable. If we connect this to the bigger picture, you can really see the evolution here. Insulin therapy has constantly tried to mimic the body's natural, immediate insulin response more precisely. These rapid-acting insulins were a huge step in allowing much finer, more adaptive control over blood glucose in the context of daily life and meals. #tag 2.4 the ultra-fast and specifics.
So we went from long-acting for baseline to regular needing a 30-minute heads-up to rapid-acting for right before meals. Now, the sources mention ultra-rapid insulins. Are we talking even faster?
Yeah.
Trying to get even closer to that instant natural response.
That's exactly the goal. The drive for ultra-rapid insulins is all about achieving even tighter, more immediate control, particularly right around meals. The faster the insulin starts working, the better it can match the body's natural, almost instantaneous insulin surge when you eat. It's about closing that time gap between eating and insulin action, minimizing how much blood sugar can rise.
Okay, so shaving off even those few minutes makes a difference. What are the examples here?
Our sources highlight two of these newer options: ultra-rapid Lispro, which has the brand name Lumiev, and faster-acting Aspart, brand name Fiasp.
Lumiev and Fiasp.
Got it. These are specially formulated, often with added ingredients to speed up absorption, so they act even more quickly than the standard rapid-acting insulins like Humalog or Novolog.
So quick you could take them after starting to eat.
In some cases, yes. That's one of the potential advantages. They might allow for dosing right before or even within the first 20 minutes or so of starting a meal, offering even greater flexibility and potentially better post-meal glucose control compared to the slightly slower, rapid-acting ones. This could be a game changer for quality of life, reducing the burden of precise pre-meal timing and giving people more spontaneity.
So putting it all together, this whole orchestra of insulins, from the long-acting background players to the ultra-rapid soloists, what does it mean for someone actually managing diabetes day to day? It sounds like a lot to juggle, but also incredibly personalized.
It absolutely is an orchestra, and understanding each instrument is key for effective management. For someone living with diabetes, it means they can have a highly personalized and adaptable insulin therapy plan.
Tailored just for them.
Exactly. Basal insulins provide that steady foundation. Regular insulins cover meals with a bit more lead time. Rapid-acting insulins offer immediate meal coverage and flexibility. And these ultra-rapid options push that flexibility even further, potentially improving post-meal control and reducing the stress of strict timing. This constant innovation really underscores the complexity, but also the incredible precision possible in managing diabetes today. It's definitely not one size fits all. It's about meticulously tailoring the type, dose, and timing of insulin to an individual's unique physiology, their diet, their activity level, their lifestyle. The ultimate goal of this remarkable pharmacological orchestra is to achieve the best possible blood glucose control, minimize those dangerous swings, and prevent the devastating long-term complications of diabetes. Each insulin represents a carefully crafted tool, a specific solution allowing patients to live fuller, healthier lives.
All right, shifting gears now. We've talked about the body's precise regulation systems for fluids and sugar. Let's turn our attention to when things go profoundly wrong at a fundamental cellular level. When we use the word cancer, it's such a huge, almost overwhelming term, isn't it? It covers so many different realities.
It really does. Cancer isn't just a major global health challenge. It's a complex biological puzzle. Generally, it's defined as a disease where cells grow uncontrollably and spread abnormally.
They go rogue, basically.
That's a good way to put it. These rogue cells lose their normal checks and balances. They multiply without restraint, forming tumors, and then they can invade nearby healthy tissues or spread to distant parts of the body metastasis. It's a fundamental breakdown of the body's own careful regulation.
And it's not just one disease, right? That's key.
Absolutely critical to remember. Cancer isn't a single entity. It's a broad group, a family of distinct conditions. It can start in almost any tissue or organ, the lining of your gut, your skin, bones, blood, brain, you name it. And that inherent diversity is why there are so many different types, each with its own unique characteristics, specific risk factors, and often very different treatment approaches. Our sources give us a few examples to explore, which helps illustrate this diversity and the unique challenges each presents.
Let's start with oral cancer. Sounds straightforward, cancer in the mouth, but what exactly does that cover? And why is understanding the specifics important for, say, early detection?
Good questions. Oral cancer refers to malignant tumors developing in any part of the oral cavity, which is actually a broader area than people might think. It's not just the inside of your cheeks.
What does it include?
It includes the lips, the tongue, especially the front two-thirds that you can move around the floor of the mouth underneath the tongue, the buccal mucosa, which is the lining of the cheeks,
Okay.
the hard palate, that bony front part of the roof of your mouth, and it can even extend back into the oropharynx, the part of the throat right behind the mouth, including the tonsils and the base of the tongue. So really critical areas for speech and swallowing.
Right, vital functions. And what type of cancer is it usually?
The vast majority, something like 90% of all oral cancers, are squamous cell carcinoma.
Squamous cells. Those are the flat lining cells.
Exactly. They're flat, thin cells that form the lining of many surfaces, including the skin and the moist linings inside hollow organs like the mouth and throat. So cancer, starting from those specific cells in the oral cavity, is squamous cell carcinoma.
Got it. And our notes mention common sites. Are there particular hot spots within the mouth where it tends to show up more often? And does knowing that help with detection?
Yes, absolutely. The sources highlight the most common sites, which is incredibly important for awareness and early detection. These include the tongue, especially the sides that the lateral borders.
The sides of the tongue, okay.
Also the floor of the mouth, right under the tongue, and the lower lip.
And the significance of those sites.
Well, think about it. These areas are relatively accessible. You can often see them when you brush your teeth or look in the mirror. This means early detection is very possible.
Self-exams or dental checkups?
Exactly. Regular self-checks are good, but routine dental checkups are paramount. Dentists and dental hygienists are often the first ones to spot a suspicious lesion. Maybe a sore that won't heal, an unusual red or white patch, a lump, sometimes even before the patient notices any symptom.
That's a huge advantage.
It really is. What's fascinating, too, is how often this most common type, squamous cell carcinoma, is linked to these specific locations. It gives us valuable clues about potential risk factors, like tobacco and alcohol use, and it tells us where to be most vigilant. It really underscores the importance of paying attention to any persistent changes in your mouth and the huge value of those regular dental visits as a key screening tool. Because if left unchecked, advanced oral cancers in these spots can severely impact speech, swallowing, even appearance, really affecting quality of life.
Okay, let's move down the line to esophageal cancer. This seems more hidden, maybe more insidious. Our notes point out something interesting. There are two main types. Their prevalence differs geographically, and one type has a specific link to a condition called Barrett's esophagus. That sounds like a lot of interconnected factors. What does it all tell us?
It is complex, but understanding these connections is really key. Esophageal cancer is a malignant tumor forming in the lining of the esophagus, that muscular tube connecting your throat to your stomach. It's the pathway for food.
The food pipe.
Right. And when cancer compromises it, it seriously interrupts that whole journey of digestion. Now, our sources identify two main types, and their differences are crucial, different origins, risk factors, even geography. The first is squamous cell carcinoma. This type usually occurs in the upper and middle parts of the esophagus.
Upper and middle.
And generally speaking, it's more common worldwide. It's often linked to well-known risk factors like long-term smoking, heavy alcohol use, and maybe certain dietary issues. The second type is adenocarcinoma. This is where the geography and that specific link you mentioned come into play. Adenocarcinoma arises from glandular cells, not squamous cells.
Glandular cells, okay.
And its incidence has significantly increased in Western countries, including the U.S., where it's now the more common type. And the key connection, as our sources highlight, is its strong link to Barrett's esophagus.
Barrett's esophagus, that sounds important. Is it cancer itself or something that comes before it? Can you explain that link? It sounds like a potential warning sign.
You've hit on a really pivotal point. Barrett's esophagus is not cancer, but it is definitely a precancerous condition. It's where the normal lining of the esophagus changes significantly and potentially dangerously.
How does it change?
Normally, the esophagus is lined with those tough, flat squamous cells. But in people with chronic acid reflux, GERD stomach acid persistently splashes back up into the lower esophagus.
Heartburn, basically, but chronic.
Exactly. Over years, this constant irritation and inflammation can cause those normal squamous cells in the lower esophagus to be replaced by cells that are more like the ones lining your intestine glandular cells. This change is called metaplasia.
So the body changes the lining to try and cope with the acid.
That's the idea. It's trying to protect itself by putting in more acid-resistant cells. However, while most people with Barrett's don't get cancer, having this condition significantly increases the risk of developing esophageal adenocarcinoma. This new cell type, while tougher against acid, is unfortunately more prone to becoming cancerous over time, potentially progressing through stages of dysplasia, which is abnormal cell growth, to full-blown cancer.
Wow. So that explains the geographical difference. Higher rates of GERD and Barrett's in Western countries lead to more adenocarcinoma.
That's a major driving factor, yes. Differing rates of chronic GERD and Barrett's in various populations, perhaps linked to diet and lifestyle, contribute significantly to why adenocarcinoma is more prevalent in some regions compared to squamous cell carcinoma. It tells us really profoundly that understanding and managing common conditions like chronic acid reflux isn't just about comfort. It can be a vital part of potentially preventing this serious cancer from ever developing. It's a clear link between a common ailment and a dangerous disease.
Moving further down, we reach the stomach and gastric cancer. Our sources highlight a really crucial point here. It's often diagnosed late because the early stages are vague or even asymptomatic. That sounds like a huge challenge, a silent threat.
It is, unfortunately, a major and persistent challenge in oncology. Gastric cancer, or stomach cancer, starts in the lining of the stomach. Most commonly, it's adenocarcinoma, similar to the esophagus type we just discussed.
Okay, gland cells again.
Right. Our sources also note it typically develops in the antrum or pyloric region. That's the lower part of the stomach leading towards the small intestine, though it can occur anywhere.
The lower part. Okay.
But that point about being often diagnosed late is the critical takeaway here. It's what makes this cancer so insidious. The stomach is a relatively large, muscular, adaptable organ. In the very early stages, gastric cancer often produces really vague, nonspecific symptoms, or sometimes, truly, no symptoms at all.
Like what kind of vague symptoms?
Maybe mild indigestion that doesn't quite go away, a feeling of uncomfortable fullness even after eating, just a little slight abdominal discomfort that comes and goes, things that many people experience frequently for all sorts of benign reasons, stress, eating the wrong thing.
Yeah, things you'd probably ignore or just take an antacid for.
Exactly. And tragically, these symptoms are often easily dismissed as just a bit of heartburn or a temporary upset stomach, both by patients and sometimes initially even by doctors if they're not persistent.
So, because the early signs are so subtle and common, people often don't seek serious medical attention until the disease has progressed much further, maybe even spread.
That's precisely the problem. By the time symptoms become severe enough to really alarm someone and prompt a thorough investigation, things like persistent vomiting, losing a lot of weight without trying, severe abdominal pain that won't quit, or difficulty swallowing the cancer has often advanced considerably.
Meaning it's harder to treat.
Much harder. At that later stage, it might have grown larger, invaded deeper into the stomach wall, or even spread to nearby lymph nodes or distant organs like the liver or lungs. This makes treatment vastly more difficult and dramatically worsens the prognosis. This silent progression is the enormous challenge for early detection and, consequently, for improving survival rates for gastric cancer. And this unfortunate reality, it raises a really important question for all of us, doesn't it? If it's so often diagnosed late, what are the wider implications for public health strategies? How do we increase awareness about recognizing persistent, even seemingly minor symptoms instead of just brushing them off?
Right. It means public awareness is crucial.
Absolutely. Awareness campaigns about these subtle but persistent GI symptoms are vital, and it underscores the urgent need for ongoing research into better, maybe less invasive, early detection methods for gastric cancer, given how quiet it is in those early critical phases. It's a stark reminder that even things that seem minor warrant attention if they just don't go away or get worse over time.
Okay, but here's where the narrative shifts, thankfully, towards something more hopeful. Unlike gastric cancer, colorectal cancer is often described as slow-growing and, crucially, highly treatable if caught early. And our notes emphasize it usually starts from something called a polyp. This sounds like a completely different ballgame in terms of prevention. Why is this such a powerful story?
It is indeed a vital point and offers a strong, proactive message of hope. Colorectal cancer affects the colon, or rectum, the main parts of the large intestine. Our sources note the common sites are all along the colon descending, transverse descending, sigmoid, and the rectum itself, the final section.
Okay, the large bowel.
Right. And like gastric cancer, most are adenocarcinomas, starting in those lining gland cells. But the profound aha moment here, as you said, is that colorectal cancer typically arises from adenomatous polyps.
Polyps, those little growths.
Exactly. They are non-cancerous growths, small clumps of cells on the inner lining of the colon or rectum. The absolutely crucial thing is that while these polyps start benign, certain types, these adenomatous ones, have the potential to become cancerous over time.
But it takes time.
Usually, yes. This transformation from a benign polyp to a malignant tumor is typically very slow. It often takes many years, sometimes even a decade or more.
Wow, a decade. So these polyps are like a warning sign, a pre-cancerous billboard giving us a huge window of opportunity.
That's a perfect analogy. It gives us a crucial window to intervene before they turn into invasive cancer.
Right.
That's incredibly powerful.
So how do we intervene?
This slow growth and origin from identifiable, removable polyps make colorectal cancer almost unique among major cancers. It makes it exceptionally treatable if caught early. And this is precisely why screening methods like colonoscopies are so incredibly effective and strongly recommended.
Colonoscopies. Right.
During a colonoscopy, a doctor uses a camera to look at the entire inner lining of the colon and rectum. They can spot any polyps. And then, this is the key part, they can remove them right then and there during the same procedure.
Remove them before they even have a chance to become cancerous.
Precisely. This isn't just early detection of cancer. In many, many cases, it's outright prevention, stopping cancer before it even starts.
That's amazing. So it's a stark contrast to something like gastric cancer, which is often caught late.
a very stark and hopeful contrast. With colorectal cancer, we have a clear, established, highly effective way to be proactive. The fact that it's often slow-growing and highly treatable if caught early, combined with the ability to remove precancerous polyps, means that sticking to recommended screening guidelines can dramatically improve outcomes, save countless lives, and fundamentally change the story of this disease. It really transforms the conversation from just treating existing cancer to actively preventing it by interrupting its development. It's a true testament to the power of screening and proactive healthcare. Hashtag the delicate dance of drug interactions.
All right, let's shift gears one last time. We've gone from the body's internal workings, fluids, hormones, cellular growth, to something external that interacts intimately with all of that: medication. Our sources include a very direct, almost stark warning. It's just a few words, but feels incredibly important. Viagra can drop pressure if they're on nitrates, hypotension. That seems like a critical piece of safety information.
It is an incredibly important note. And while it's concise, it encapsulates a massive fundamental principle in pharmacology, and even more critically, in patient safety. What it means is if a patient is taking a drug like Viagra or Cialis, these are in a class called phosphodiesterase 5 inhibitors, primarily used for erectile dysfunction, but sometimes also for pulmonary hypertension.
High blood pressure in the lungs.
Right. If they're taking one of those, and they're also taking medications known as nitrates, there is a severe, potentially life-threatening risk of hypotension. That's a dangerously low drop in blood pressure.
Okay, Viagra or similar drugs plus nitrates equals dangerous low blood pressure. Why? What's the mechanism?
Good question. We need to understand how these drugs work. Nitrates like nitroglycerin, isosorbide mononitrate, or dinitrate are commonly prescribed for heart conditions like angina, which is chest pain from reduced blood flow to the heart.
And nitroglycerin, right. People put it under their tongue.
Exactly. Nitrates work by causing blood vessels throughout the body to relax and widen or dilate. This improves blood flow and reduces the heart's workload. Now, drugs like Viagra and Cialis also work by causing blood vessels to relax and widen, though they use a different biochemical pathway.
So both types relax blood vessels?
Both do. And when you combine them, their effects on blood vessel dilation aren't just added together, they become powerfully synergistic, multiplied almost.
Uh-oh.
This combined potent relaxation can lead to a drastic, sudden, and precipitous drop in overall blood pressure, far beyond what either drug would cause on its own.
And a sudden, severe drop in blood pressure. That's not just feeling a bit dizzy, is it? That sounds like a real emergency.
You're absolutely right. It is far from minor. Severe hypotension can drastically reduce blood flow and oxygen delivery to vital organs, the brain, the heart itself. This can lead to symptoms ranging from severe dizziness, fainting, loss of consciousness, all the way to medical shock, organ damage, or even catastrophic events like a heart attack or stroke.
Wow. Life-threatening.
Potentially, yes. It's not just feeling lightheaded. It can be a true, immediate medical emergency requiring rapid intervention.
Right.
And this is precisely why it is an absolute ironclad rule for all healthcare providers. You must get a complete and accurate list of all medications a patient is taking. Prescription, over-the-counter, herbal remedies, supplements, everything.
Single thing.
Every single thing. It's the only way to identify and prevent potentially devastating drug interactions like this one. This seemingly small, concise note in our sources highlights a truly massive principle in pharmacology. Interactions can profoundly alter and often intensify the intended effects of medications, sometimes with dramatically dangerous consequences. It's a stark reminder that medicine is about understanding incredibly complex, interconnected systems, not just isolated components. This specific interaction between PDE5 inhibitors like Viagra and nitrates is a classic textbook example taught everywhere because of its potential severity. It's an absolute contraindication. Just don't combine them. It underscores the precision and diligence required in every prescription, every dose, every patient conversation. Hashtag Dag Outro.
Wow. Okay, what an incredibly insightful and intricate journey we've taken today. We started way down at the microscopic level with cellular hydration, really appreciating the precise science behind IV fluids, how different concentrations can be such powerful tools.
Yeah, from simply replacing volume to actively shifting water between compartments.
Exactly. Then we move to that delicate dance of insulin management, seeing how that whole orchestra of different insulin types works together to regulate blood sugar with such nuance, trying to mimic nature.
Mimicking the body's rhythm, yeah.
Yeah.
The basal background and the mealtime bursts.
Right. Then we delved into the tougher topic of cellular malfunction with cancer, exploring different types, oral, esophageal, the hidden challenge of gastric, and then that really hopeful story of colorectal cancer, where prevention through screening is so powerful.
Showing the vast diversity of cancer and the importance of understanding each type's specific characteristics and vulnerabilities.
Definitely. And we wrapped up with that critical reminder about drug interactions, using the Viagra and nitrates example to show how vital it is to understand the whole picture of what someone is taking.
A powerful lesson in pharmacology and patient safety, for sure.
So what does this all mean for you listening? Today, we've navigated from, the molecular mechanics of fluid shifts right up to the big battles against diseases like cancer. It's a powerful reminder of how intricately, how brilliantly designed our bodies are.
And also how vulnerable they can sometimes be.
True. And how profound the impact of medical science can be when it's applied with precision, deep understanding, and constant vigilance. As you go about your day, maybe just take a second to consider how these unseen processes are relentlessly, dynamically at work within you, constantly maintaining balance, fighting off challenges.
Pretty awe-inspiring when you think about it.
It really is, and how every tiny detail, every nuanced fact we explore today contributes to that much bigger picture of human health and well-being. It's a testament to the incredible complexity and resilience that underlies your very existence.
And maybe this journey raises a question for you to think about. How might a deeper understanding of these fundamental biological and pharmacological principles, fluid dynamics, cellular control, drug interactions, how might that empower you? Not just in a medical situation maybe, but just in appreciating the incredible precision, the relentless innovation, and the immense care involved in maintaining health. What new questions does this deep dive spark in your own curiosity about the human body and about the medical advancements designed to support its incredible capabilities?